We will now open the floor up for a live Q&A session with our panel. Please use the Q&A button at the bottom of the panel to post your questions. Thank you.
Right, so I hope you all agree with us that having 2 or more health conditions during pregnancy is an important issue. Our care services quite often focus just on individual health condition, which can often be quite confusing and quite stressful for women who have 2 or more health conditions undergoing a pregnancy. We already have one question, so let's go on to that question. So interesting conclusion about women in deprived areas likely underdiagnosed with chronic diseases. What do you think about outreach programs in deprived areas to improve prenatal care? Can I pass that question to Catherine Nelson-Piercy, Professor Catherine Nelson-Piercy?
Thank you, Krish, and hello, everybody. That's a really interesting question from Fran. I think we accept that we need to do more to access disadvantaged or disengaged populations. And yes, I do think that probably involves outreach care. This is, I think, one of the few advantages of COVID, that it has taught us new models for care and how to reach women who can't or won't come to secondary care or even to primary care. So I think it's an interesting question. I think it involves more exploration. It's obviously quite an expensive thing to do. But I think we need to accept, if we're going to get rid of variation in care and be able to offer all women high-class holistic care, then some form of outreach, I think, probably is going to be necessary. But thank you for the question.
Thank you, Catherine. It also has to be mentioned there are a few issues here. One, of course, underdiagnosis of health conditions. The second is naturally what we observed, for example, in the Scotland data, that we did find deprivation was associated with health condition. And the reason being, when it comes to severe health condition, we can see that more deprived people seem to be affected more. When it came to much more less severe health condition, like for example, allergies or skin health conditions, it is likely because they seek less care or access care, and that may be one reason. Anything further to add from any of the panel members? Professor Catherine Abel?
Yes, thanks, Krish. Lovely to be here, and it's so nice to hear these questions and results from the panel. So one of the things that we do know about women with mental illness and women with mental illness in the perinatal period is that they're more likely to be young women, more likely to be deprived, and less likely to be able to take up even very good evidenced intervention. So, building on what Catherine said earlier, there are real challenges to reach these underserved populations because we can't just use our models that we would, our general public health models. So, for example, one of the really interesting findings that may illustrate this point is that we know, for example, with sudden infant death syndrome, that there are very clear causal pathways to that. So we know that smoking and baby sleeping position are absolutely causal in the pathway to risk for sudden infant death syndrome. And so there's been enormous success in public health interventions, educating women and explaining how to try to reduce that risk by changing baby sleeping position and encouraging women to stop smoking. And in fact, stopping smoking occurs most successfully in women in the first trimester of pregnancy. But what we see is it doesn't happen successfully for women with mental illness in the first trimester of pregnancy. And so their relative risk to the background population actually increases following that public health intervention. So they're not accessing the information that we've made as a public health message in the same way as other people. So something in relation to their mental health problems and their mental health conditions prevents them taking up that message and improving their own health health inequalities, if you like. So that's something that's really a challenge for all of us to think about these people who are multimorbid, likely to have a mental health condition, and how we address that difficulty and challenge of taking up what it is that we see they may need in addition to what we're giving the general population.
Thank you, Catherine. That's very useful. We got another question here. How many women from deprived areas are working in your PPI group? It is so difficult to get women from less than optimal health and social care backgrounds to join groups because they can feel overwhelmed by very articulate fellow members. Tough one to deal with it, and it would be good to hear your comments. So maybe I'll pass that question first to Nawai, who has been involved in research for a number of years, and also has kindly helped us throughout our research journey up till now. Nawai, over to you.
Thank you, Krish. Yeah, no, this is definitely a massive issue, and trying to make sure that we're inclusive. I mean, for our group, luckily both Rachel, who can't join us today, has been amazing, and her and I have been the co-applicants on this piece of work, but we've both really tried to make sure that women with more long-term health conditions have been able to be part of this, and also partners, men, carers, but that's a bit hard, that's a bit harder. But we've used our networks and our connections to try and really disseminate the message that we were creating this patient and public involvement group, and try to be as welcoming as possible. I mean, one of the barriers that we found is that sometimes it's difficult to come forward. So even if you have an interest, you might not really, it's difficult to talk about your own conditions. So that's been tricky, but we have an amazing group, and we've tried to make sure that we do have a mix, but enough people in the group that everyone's voices can be heard in the group. I think as we take this work forward, we will try and make more efforts to also make sure that, you know, we can include the different countries as well within the team. But I totally agree, it's really difficult, and we've tried to use our networks the best way we can, and we're lucky we do have good networks. Yeah, so hopefully going forward we'll work on this.
Thank you, Nawai. So we have a question around what are your thoughts on targeted ethnographic research approaches to develop meaningful relationships with people who live in difficult social and health circumstances? Can I pass that question to Dr. Rebecca Taylor?
Thanks, Krish, and thank you, Marlene, for the question. So I'm co-lead of the second work package, which is our qualitative work with women and health professionals, along with Louise Lowcock and Myred as well as with us on that work package. So in terms of our approach, we're planning to do interviews with women and their partners across all the 4 nations, and to have a really focused approach on getting really diverse sample and reaching out to those women who the data and our participant patient involvement groups are going to tell us are important to work with. In terms of targeted ethnographic approaches, that isn't part of our plan at the moment because it would require a really intensive approach in a single area. But what we are going to do is to, when we identify who the particular women are that we're not reaching through our first pass approach, which is to work through charities, through social media, through our patient involvement groups in healthcare and in research, and through clinicians as well. If that's not working for us, then we are absolutely flexible to think about other ways of reaching out and identifying those women based on who we're able to recruit, and any groups that we're not reaching. Does that answer your question?
Thank you, Beck. So one of the questions, we talked about deprivation. We didn't mention a lot about ethnicity. One thing is, of course, this is preliminary work. We are looking at only data in 2018. When we look at a whole 20 years of data, we might be able to find things that may have been difficult with a limited data set. So in order to answer that question, can I ask Ing, what did we observe when it came to ethnicity?
Yeah, so again, interestingly, it showed that non-white ethnicity were less likely to have multimorbidity. So we haven't specifically looked at ethnicity within social economic deprived areas as such, but just ethnicity itself, when we put into analysis, it seems that, again, non-white ethnicity seems to be less, but we think this, again, may be related to different health-seeking behavior.
Thank you, Ying. And also we have to be careful how we interpret these databases. So is it a true association, as in, is there actually less health condition, or is it an issue about access to healthcare? And how do we make that access to healthcare better? So while we wait for additional questions, can I ask a question to Mary? Mary, you mentioned particularly general practitioners and health professionals struggle to understand a lot of the issues you had. Do you think one reason may well be they just don't have any information about health outcomes or the journey of women with 2 or more health conditions?
Hi, Krish. From my own personal experience, I think there's extensive understanding with regards to some of my conditions. With regards to endometriosis, I've been told by many medical professionals that it used to be very overdiagnosed, and as a result now it's very underdiagnosed. I think the average diagnosis time is something crazy like 12 years. It's something nuts like that. So I don't really know whether I can say whether that is well understood or not. My personal opinion is not really, but the other conditions I think really are.
Yeah.
I think the complications arose then when you combine these conditions together. Mm-hmm. And then there seemed to be kind of a lack of understanding in terms of the interactions. Sometimes it felt like the easier response was, oh, that's very complex, that's very complicated, or you've been through the ringer, that's you've been through a lot. But it kind of felt like sometimes it came down to lack of time, a lack of patient time, first of all, for medical professionals to review my notes prior to appointments. And therefore then relying on me to advise of my medical history, to advise the interactions, to advise of medication, to advise strengths of medication, to advise dates of surgeries. So that put on a lot of mental health pressure, because you would leave appointments and thinking, oh, I forgot to tell them about that, or maybe I told them the wrong date for operation, or did I tell them the right strength for that? So personally, I think because I had very complex issues over quite a short period of time, and initially didn't have the greatest support, that I became my own advocate, and I requested my own notes, and I kind of jotted down things and queries and stuff. So I very much became my own advocate. But I imagine a lot of mums don't do that, or aren't in a position to do that. And that worries me that a lot is potentially being missed from there. But it's one thing looking at health conditions in silo, but that's not enough. You know, look at endometriosis in silo, but can you look at endometriosis combined or potentially then a cause of kidney issues, and then potentially the reason why I lost a kidney? Can you then, when you add in inflammatory conditions into that, it's too easy to try and look at them in silo, whereas we need to kind of look at it in a more joined up approach. And I think, you know, as kind of Ing looked at the results, you know, there's lots of what we in the PPI panel discussed is lots of these kind of more common, potentially less severe conditions coming out. So like asthma and skin conditions and allergies. But, you know, what about these really complex conditions, or these really complex situations where you have more than one complex condition then mirror together? So it's the one thing having one complex condition, but then having 3 complex conditions together is just a whole different scenario situation. I don't know if that really answers your question.
It does a lot, and it also poses a lot of questions as much as answers. So naturally, we are seeing health conditions clustering together, something we are going to do next. We want to understand why do they cluster together? And we want to know how can we develop care pathways when there are two or more health conditions? And what impact that has on the health outcomes, both in the mother and the offspring or the baby. Because without knowing that, it's really difficult to develop those interventions that can mean a lot in terms of improving care. So with that in mind, can I ask Holly, obviously, naturally we saw mental health condition dominating there. 4 in 10 women or 1 in 3 women have had an experience of having a mental health condition from their teenage years going into pregnancy. And they seem to combine a lot with physical health conditions, sometimes influencing them or coexisting. What do you think are the reasons, and how should we sort of shape our research to understand this better?
Thank you, Krish. Yes, so there are different pathways to multimorbidity before you become pregnant, and there are different ways of conceptualizing the idea of complexity. It was really interesting to listen to Mary and her experience and how she had to deal with multiple complex physical conditions. But another way to a complex pregnancy can happen quite early on in adolescence, where you acquire complex mental health conditions, which are very serious, which lead you to be admitted to hospital multiple times. And actually, we know that if you suffer with a mental health condition in adolescence, you're far more likely to become pregnant than someone who doesn't suffer from a mental health condition in pregnancy. And some of the determinants for having a pregnancy in adolescence, or as a young woman, sort of less than 20, relate to adversity in your childhood, circumstances of how you were brought up. But what's really interesting is that those circumstances which predispose you to those mental health conditions in adolescence actually predispose you to physical health conditions later on in life. So they are part of a really important pathway that I think we need to understand. And I would hope that some of this research, one of the impacts will be to rethink how we look at complex pregnancy and how we protect those women going through their journey through antenatal care. Thanks.
So sorry.
Krish, could I just add one very
Yes,
quick
please.
point to that, which is, and Holly has done a lot of the work on this, so she'll know this also, but is that if you're a woman coming into pregnancy with a mental illness, then your risk of obstetric and childbirth related problems, so problems during the pregnancy, problems intranatally, and indeed physically postnatally, these are obstetric problems, is far greater. So it's not just the notion of lots of adversity causing the mental illness pathway, but it's also the way in which the mental illness then in some way is a mediator or cause of physical problems associated with obstetric, very, very high obstetric risk. So again, it's this notion of reconceptualizing complexity in pregnancy.
Thank you, Catherine. So we have one more question. So we are coming close to the question and answer session, and I can see more questions coming through, but we will make sure we answer those questions. We have another couple of question and answer sessions. So one of the questions here now we have is, how do we improve pre-pregnancy counseling services for women planning to start a family with multiple medical conditions? Very important question. We know preconception care is minimal at the moment, and there is a lot to do. And when we think of women with 2 health conditions, then there is a lot more to do. So may I ask Professor Catherine Nelson-Piercy first to comment on that?
Thank you, and thank you, Latha, for the question. It's one of the most important issues actually facing us is not just pregnancy care, it's pre-pregnancy care and post-pregnancy care. And we really hope that this research will inform how we develop these services and the pathways for women. But the answer to your specific question is, I really hope, obviously I have a vested interest as an obstetric physician, but one of the advantages of obstetric physicians is that they can deal with multiple problems. They don't just deal with lungs or hearts or epilepsy or asthma, we can do it all. And so if GPs had access to an obstetric physician trained in each region, then that advice becomes much more readily available. And I really hope that the advent of maternal medicine networks, which are currently only planned in England, but there are lots of noises from Scotland and Wales that they want to do the same thing, that this will improve access to care for women with multiple physical health conditions. For mental health conditions, I'm sure Catherine Abel's better able to comment than I am, but the profile of perinatal mental health has been raised through data collection, and similarly this research will provide data to inform policy, to aid funding and availability of these services. There's a knowledge gap for these, and Mary's comments are so pertinent and illustrate so well the fact that you can't send women off to 5 different clinics and 5 different pre-pregnancy counselling appointments. They just want to go see one person, or maybe 2, who can bring the whole thing together and come up with a plan and give that woman confidence and reassurance. And that goes for her mental health as well as her physical health. It sounds like utopia, but I am an eternal optimist, and I really think that it is deliverable. But this research provides a much needed factual database, because quite frankly, policymakers won't believe us otherwise if we don't illustrate what the burden of disease is. Sorry, I'm ranting a bit, I'll shut up.
Okay, Catherine. So just to be clear, so evidence-based healthcare means we need to have the information to make decision. And what the question was, how do we provide preconception care? But when you take health condition, long-term health conditions, there are 3 key areas. One, we want to prevent, that will be the greatest thing. And the second, if we can't, we want to detect them early. And third, we want to manage them well before pregnancy. So there is a whole range of things we have to do. We need to take a life course approach, and that means we need life course data to understand these issues. And that's one thing we are going to do, take a whole range of database. We are very fortunate also in this context to ask one last question before Ing tells me that I'm running over time. Sinead, can you tell us about SAIL database? Because one of the database we are using is SAIL database, which is really nice in the sense it's linked to so many databases, gives us a really good life course approach to understand women's health before they go into pregnancy.
Yeah, in Wales, we have linkage to GP data for nearly everyone in Wales. Everybody in any hospital data, we have education linked. So that means we can look at school readiness and things like that for children, but also often education for the mum. We have linkage to what's called the maternal indicators data set. So that enables us to look at features of the pregnancy. We link to social care data sets as well. We have linkage for things like the census, which enables us to look at deprivation, occupation, ethnicity. So lots of things using multiple linked data in order to look at before the pregnancy, during the pregnancy, and after. Through all healthcare and also, like I say, education and other workplace data sets as well. So things like occupation of people working in schools or the NHS. So lots of linkage there. One thing I would also say is some of the findings here were suggesting lower levels amongst deprived women or ethnic minority women. And that's not borne out when you do cohort studies where women are asked about behavior, symptoms. So we do know that what you're getting from routine data isn't always the truth, if you know what I mean, as well. So
it's about understanding and making sure we use a whole range of database, which we'll come to later because we will be using cohort data sets. I'm going to bring this to an end for a break if I'm writing. And in doing so, there were a couple of questions, one on prescription, which we will answer after the break because we are going to talk about that. Secondly, there was a question about, a very important question about how many women with multiple health conditions in the first place become pregnant, say.